and welcome. I'm Khushbu and you're watching Health Mantra. Today we are here with two very special doctors. Today's episode aims at helping you diagnose the early signs of a stroke. Stroke that is something that takes maximum lives in India, or at least it leaves you disabled. Here when we have these doctors we get to learn more. Maybe we'll be able to help someone around us while they are experiencing some signs of this. So let's get to know the doctors first. To help us understand better here today, we have Dr. Safal Shetty. Dr. Safal Shetty is a consultant in neurology, and Dr. Charudutt Sambhaj. Dr. Charudutt is a consultant in interventional neuroradiology. First of all, doctor, as we speak of a stroke, what exactly is a stroke and how can one identify or diagnose it?
Stroke is, first of all, a medical emergency. Stroke is a condition where a person doesn't get enough blood supply to the brain. Okay, so blood supply gets completely cut off, either because there is a block in the blood vessel which is going towards the brain from the heart, or there is a rupture of the blood vessel which is going towards the heart. So we divide the stroke into two different types. One is ischemic, where there is clot in the blood vessel which blocks the blood supply and blood doesn't go into that particular aspect of the brain and causes symptoms. Other one is hemorrhagic, where the blood vessel ruptures causing bleeding in the brain. Hence the blood in the brain can cause some amount of mass effect on the brain and cause symptoms. Right now over here we'll discuss mainly about the ischemic aspect, okay, where there is clot in the blood vessel and the blood supply is not happening to the particular aspect of the brain and causing the symptoms. So whenever someone has stroke or whenever someone is having an impending stroke, we find some classical symptoms. So symptoms have to be sudden in onset. That is the most important part. So it has to be sudden. That means patient was seen absolutely okay few hours back and he's developed a symptom. So what are the symptoms? Some of the common symptoms which we see in patients, and we go by a mnemonic called B fast. So B is for loss of balance, if there is sudden loss of balance. E is for loss of vision, if there is a sudden loss of vision in any one of the eyes. F is facial weakness, if there is drooping of one side of the face or there is angle of deviation of mouth to one side. Next is A, arm weakness. Next is S, which is speech, loss of speech or slurring of speech. And last one is T. So B fast, T is time. Okay, so someone who has had these symptoms, any one of these symptoms, has to come to the medical attention within 4.5 hours. That's how it is important. We'll speak further on why it is important to come within those 4.5 hours. But the symptoms are these: loss of balance, loss of vision, facial weakness, arm weakness, and loss of speech or slurring of speech. And Dr. Charu will be able to tell more about the diagnosis aspect.
So as Dr. Safal has discussed about what a stroke is, you can have sometimes a stroke looking event which may not be a stroke, or the stroke could be because of bleed in the brain, or it could be because of lack of blood supply. So lack of blood supply is because of a block in the artery, which could be cholesterol accumulation, or sometimes a clot coming from the heart or anywhere in line or in path of the from anywhere from any of the pipes or the vessels which supply blood to the brain. A clot can go from anywhere from there to the brain, and this causes a stroke. So basically, to identify the anatomy of the stroke or whether this patient really has a stroke, we need to do an imaging. So imaging can be CT scan or an MRI, and whichever is available to you at the earliest, you should get a CT or an MRI done. So at our place, we do a MRI for patients who can cooperate. Many times these patients can be restless. So an MRI needs the patients to be a little more still and allow us to do the scan, which takes around 10 to 15 minutes. Whereas in a CT scan would take hardly a minute or so to do the scan. And the main reason why we do imaging is that we want to know whether it's really a stroke and whether it's a bleed or it's a blocked artery. So because the treatment the further treatment depends on what is the diagnosis, whether it's a bleed-like stroke or it is an ischemic stroke where you have a blocked blood vessel. So the anatomy of this problem is better delineated by CT or MRI, and MRI scores a little better when it comes to delineating all these problems together. Along with that, we do something called as vessel imaging also. The blood vessels which are supplying the brain are also imaged on the CT scan or the MRI, and we call that angiography. So MR angiography or CT angiography. So along with the scan to find out whether this patient really has a stroke, we would further go ahead and do something called as MR angiography, which we can do without injecting dye when you do it with an MRI. A CT scan would always require dye to be injected through the veins to delineate the arteries. So once this anatomy of the problem is known, whether this patient really has a stroke, or that is what is the first thing to be known, or it was just a mimic, stroke mimic. Stroke mimics could be anything like tumors or some conditions like demyelinations can also present like stroke. So once we isolate these conditions and then zero down to a diagnosis of ischemic stroke, which is commonly treated, the hemorrhagic stroke usually is conserved unless it has a lot of compression effect on the brain. We take them for decompressive surgeries. So most of the times it is an ischemic stroke where we have to deal with or give medications. So once we identify this patient to be having an ischemic stroke, and then we can actually motivate or mobilize the rest of the team to further treat this patient with either medicines or some other therapies which we'll discuss further.
Okay. And doctor, what exactly causes a stroke?
So there are various risk factors for stroke. So there is something called as modifiable risk factor, that is basically uncontrolled diabetes, uncontrolled hypertension, smoking, okay, and there are non-modifiable. So age is a non-modifiable risk factor. So obviously we cannot reverse aging. So a person who is elderly has higher chance of having stroke than a person who is younger. Not that we don't see patients with stroke in younger age, but relatively we see patients who are elderly or who have crossed 60, whom we see in our routine clinical practice. So these are the risk factors. A person who has these risk factors has higher chance of getting a stroke. And as Dr. Charu told already, one of the thing is that if a person has a clot in the heart, that clot can go up to the brain also through the blood vessels which go from the heart to the brain. So that is one. Or if there is excessive cholesterol deposition because of excessive cholesterol in the blood itself. Or diabetes also can cause some cholesterol changes in the body and can deposit in the blood vessel. If the cholesterol deposition is higher, then the blood vessel gets clogged and a person can have stroke. So these are some of the common ways of how a stroke can occur. But there are risk factors which we have already discussed. I would like to add one point what Dr. Charu mentioned about stroke mimics. A person has had a seizure or a fit can very well mimic stroke. Okay, if a person has had a seizure or a fit and it was one-sided and no one has seen it, when the fit has gone, a person can have that side weak and it can get confused with stroke. So that's why it becomes important to take the history from the patient who has, if he is unable to speak, if we have to take the history from the relatives. So it becomes important for us to know who was with the patient when the patient was seen. So that is something I would like to add on. So these are some of the common causes of stroke, how the stroke can be seen.
So usually in stroke you have an immediate cause, which is as we described earlier, is usually a clot or a vessel that is blocked or narrowed. And these conditions are usually slowly building up because of the conditions that Dr. Safal has already mentioned, like diabetes, hypertension. Many a times you have heart conditions which can give rise to a stroke, where your heart has become weakened because of your previous heart attacks, where the heart is weaker and that part of the heart is not moving well. When something doesn't move well, or the part of the heart doesn't move well, you have chance of clot building up there. So something to remain fluidic, you need it to be constantly moving, like your buttermilk, they keep moving it, and then so if you have the blood starts clotting when it's not moving. So if your heart is weakened or has a area in the heart which is weak, that part of the heart can generate clots, and those can migrate to the brain and give rise to a stroke. So this all we would analyze when a patient with stroke comes to us. But more importantly, we'll be looking at what is the immediate cause, whether it's the vessel that is blocked, whether the vessel has got some separated layers, which we call dissection. Many a times you have trauma to the neck, or some abnormal movement of the neck, or sudden movement of the neck where one of your vessel has separated. There are layers in the vessel which can separate out, and if they separate out, we call it dissection. These patients also will present with stroke.
And so they are usually younger.
Those are usually younger. So the cause of stroke could be again a clot, a dissection, or a vessel which has narrowed and then suddenly got blocked, because the narrowed segment, again the flow becomes slow, and the vessel can get thrombosed or get clotted because the flow is slow. So these are the immediate causes of stroke which we identify, because we need to start something, a treatment that is immediate. And the associated conditions like diabetes, hypertension and all, we would treat them to prevent strokes or a second attack of stroke, and keep them in control to prevent further strokes.
And doctor, previously both of you all mentioned that a patient needs to hurry up, basically time. So what's the importance of time in this? Why is it necessary that you have to hurry as soon as possible?
So time, as I told, that as the blood supply is getting reduced to the particular aspect, to the particular part of the brain, the nerves or the brain cells starts getting, decreased oxygen, so they start dying. And there's a particular time after which we cannot salvage those dying blood cells. They're already dead. So that means to say that the disability which the patient is going to have is going to be permanent, or it's going to be definitely not how he was. So that's why the time which has been told has to be less than 4.5 hours. Okay, anyone who is suspected to have stroke should come to the medical attention, should seek medical attention within 4.5 hours. Okay, and not wait thinking that I have not had food, that's why probably my one side of the one arm is weak, or I'm not able to speak properly. So they should not wait. Moment they feel that something is wrong, or they are not able to speak, they are not able to lift up their hand, they are not able to see properly from one eye, they should seek medical attention. Unlike the patient for the heart attack, there is no pain here. So that is the differentiating point. So people who have heart attack, they'll have pain and they are aware that there is an impending doom happening. So they seek medical attention quickly. But over here, there is no pain. So most of the patients tend to ignore it, thinking that it's going to be okay. So let me just go to sleep, or let me have some food, I'll be all right. Fortunately, some of these symptoms may resolve, fortunately, but some of them might not resolve also, and it becomes severe and severe. And some of them might have gone to sleep and they wake up with a much more devastating weakness on one side of the body. At that point of time, we don't have that window, or the time period of 4.5 hours is already lost. So we cannot give a definite treatment to reverse the whole process. So with advent of new medications and technology, we are able to reverse these symptoms also with the help of an injection, okay, which we'll be discussing a little further, and also other modalities of treatment which Dr. Charu will be discussing. Okay, so that's why the time is important. So brain cells have a particular time duration during which they can survive. So if you do not reverse, if you do not open up the clotted blood, or if you do not open up those vessel which is blocked, then the brain cells die. So once the brain cells die, the damage is permanent. So that's why the time is important. So imagine a person who's a painter, and he's a breadwinner of the family, and his only job is painting, and he develops a stroke on the right hand, and he doesn't come into the medical attention early. So we can say that he might not be able to paint again. So that such is the devastating effect of a stroke, and it can cause significant impact on the family. Okay, so that's why we keep saying that it's important you guys should come in at the earliest, and we keep building awareness about the whole thing. So that's why the time is important.
So actually, when you get a stroke, it's with the patient as well as the team that is managing to reduce the time for therapy. The reason for that is the brain that represents your hand or leg or your speech area is very small. So when a blood supply, a blood vessel which is supplying that area gets blocked, you immediately start having death of cells, and millions of brain cells will die with passing time. So as we said, we have a very narrow window, that is around 4.5 hours to 6 hours when your stroke is on the front side of the brain. So we divide the brain into the front side and the back side. So when you're looking at the front side of the brain, which represents your voluntary movements, that part, and speech, that area is that area gives you a window of around 4.5 or around 6 hours to maximum around 8 hours to treat. Thereafter, if we try to treat or intervene, there are chances of having complications. So we avoid, or we tailor the treatment based on the age of the patient and see what is the anatomy of the problem by imaging, and see if the core of the brain that is already dead, whether it's small or big. So as time passes, the core of the brain that is dead starts increasing, and there is a brain around that core of the brain which is still salvageable. So that brain is hibernating, or it is getting supply from the surrounding or the neighboring arteries or the blood vessels, which keep this brain intact. And that particular concept or that particular reason for that is a collateral supply. So collateral supply comes from the blood vessels which are in the neighboring territory, and they keep this area alive for some time till you can revascularize or open up the blocked artery. So if you don't intervene in this 4.5 to 6 hours time, then this brain which is at risk also will die. Now when you look at a small representation in the brain which looks at a large area of body to be controlled, then you can have a patient who is not going to be independent or not going to have an independent life and life without support if we don't revascularize this within that window period. So time is very important here, because the therapies can be given only within this window period, that is 4.5 hours to 6 hours for the front circulation, and the back circulation we still can extend this to around about 12 hours, 8 to 12 hours.
And
Again, when the patient has presented with these symptoms, we'll not be able to tell whether it is in the problem is in the front side of the brain or the back side of the brain. So irrespective of the time, irrespective of the site, we need to still get medical attention. Only when we do the imaging, we get to know whether it is in the front side or on the back side. So anyone who has suspected stroke should come within 4.5 hours. Earlier, the better. Don't even wait that I still have 4.5 hours, so I'll go a little later. As soon as you realize, you have to go.
So actually this should be looked at something like a response at the pit stop, where your car comes and they change the things and see what's the health of this, and then they send the car back. So it's all the people who are responsible for the treatment, as well as the family members, have to respond in that kind of a mindset and get the patient to be evaluated as well as treated within that short window period.
I hope you have heard all that. 4.5 hours, we have to be careful. Any signs of it, you have to consult a doctor. So doctor, as we speak of it, how is an acute stroke treated?
I had already mentioned about an injection which can be given. So if a patient comes within 4.5 hours, we do the necessary brain imaging, and then we decide whether the patient is capable or is a candidate to get the injection. Not that every patient should receive it. If a patient is a candidate, then we go ahead and give it. Okay, so injection is given over the period of 1 hour. Okay, there's another injection which can be given as a bolus. That means to say that it can be given at one shot. So there is a 3 to 6% risk of having a complication because of the injection, in the form of bleeding in the brain. Because of the injection, it can occur. So this is with respect to the injection. After giving the injection, there is a possibility that the person might not improve if there is a clot in the main vessel. Okay, that's where Dr. Charu comes into picture, and there are therapies where we can go in and remove the clot from there. That's where Dr. Charu comes in.
Actually, the window is short. So when you have a patient who's coming to the ER with a stroke or stroke-like symptoms, there's not much that the ER team has to do. They just pass the IV line and then send the patient for imaging. We diagnose that this patient has a block in the artery, and this patient is in the window period. So the first thing that we start, or the first therapy that is given to the patient, is starting blood lysing agents or blood clot busting or breaking agents, which we call thrombolysis. So this is sent in through a vein in the periphery of the hand or in the arm, and this goes to the brain, reaches the brain, and then lyses the clot. Now this needs some time. So in the meantime that this medicine is taking its effect, still brain cells are dying. There are times where this medicine may not work if the clot burden is high, or the vessel that is blocked is too large for this clot busting medicine to reach there and break it. In those scenarios, it was since 2013 and then more so in 2015 that a newer therapy started getting developed, or the research started coming in, and more and more studies were released or published in 2015 where they started removing the clot directly from the brain, and this therapy was called mechanical thrombectomy. So, and this was what Dr. Safal discussed earlier, is called chemical thrombolysis. You break the clot by giving medicine, and here you actually go inside and you put in something like a fishing net there, which we call a stent retriever, or we put small catheters or tubes there and connect it to a suction machine with very high suction pressures and just suck out the clot. So either you suck out the clot or you put in a stent retriever, which is connected right up to with a wire right up to the entry site in the groin. So you enter from the groin, you reach the site of the brain with these small tubes and wires, which we call catheters and wires. Reach there, place this fishing net like device, which is called stent retriever, engage the clot in that and pull the whole assembly out. And this is called stent retriever mechanical thrombectomy, and if you use a suction device or suction catheters, we call it suction thrombectomy. So these therapies, these two therapies actually changed the way we started treating stroke since 2013 and 2015, to the extent that the functional independence that patients started getting improved by around 20 to 30% over and above the chemical thrombolysis. So it's not that we started doing this and the chemical thrombolysis was stopped, but when you put them together, that is chemical thrombolysis as well as mechanical thrombectomy together, the results were far better, because you could actually put the fishing net like thing, the stent retriever, get the clots out, but there could be small fragments which could still go ahead, and you may not be able to pull them out with some mechanical devices, and these small particles which have gone distal ahead may still need a chemical thrombolysis. So when they are put together, and when a stroke is treated together with intravenous thrombolysis, and then along with that you do a stent retriever thrombectomy or suction thrombectomy, you can actually clear this clot within 30 minutes to 45 minutes. So we look at treating these patients in a time frame of around 30 to 45 minutes. So we call it door to needle, or door to clot retrieval time should be around 30 to 45 minutes. So that is what we try to achieve. So when this patient comes in a window period of around 4.5 to 6 hours. So for injections, we look at a time frame of 4.5 hours. But when you are doing therapies like stent retriever thrombectomy or clot retriever, we can extend it to 6 hours. Many times we have patients whom we cannot give the injection. So in patients like who have undergone recent surgery, so the surgery site is going to bleed, because if you are going to lyse a clot, it is going to lyse the clot which is actually holding the surgical site. If patient has had a recent head injury or even a recent stroke, one more stroke earlier to this, which was within a time frame of around 3 months, you can't give these chemical agents like the ones which we use for IV thrombolysis. In those scenarios, we can still do mechanical thrombectomies and get the clot out, because we don't then need an IV thrombolysis because you're pulling out the clot.
So finally, doctor, is there a way that we can prevent a stroke?
Definitely. We have to take care of the risk factors. So if a person has diabetes, it has to be kept under check. If it is uncontrolled, it has to be brought back to control. Not that if it is controlled, patient will not have stroke, the chances go down. Okay. Similar aspect with respect to hypertension also, or blood pressure. So it has to be brought under control. If a person is smoking, then definitely needs to quit. If quitting is becoming difficult, then he has to take help. Mental health expert needs to be brought in, and then it can be stopped. If a patient has an underlying heart condition, or there is something called as atrial fibrillation, where a person has an irregular heartbeat. So whenever there is irregular heartbeat, there is a possibility of causing a clot inside the heart, and the clot can go up. So that has to be taken care of. And there are medications which we give to take care of these such kind of conditions. And exercise is another important aspect. It's advised that you have to do moderate exercise for 30 minutes, 5 days a week. And another aspect would be to make sure the cholesterol is under control. So cholesterol check needs to be done, and then that has to be taken care of. So this is with respect to preventing a stroke which has not yet occurred. Suppose someone has already got a stroke, and we can give medications called blood thinners. Basically they are blood thinners, where we can make sure that patient doesn't have any more strokes. So these are the important aspects of preventing the stroke.
So when you prevent a stroke, you are either trying to prevent a stroke which is not yet happened to this patient, and there you look for the risk factors like diabetes and hypertension or high cholesterol levels, as Dr. Safal has discussed. So, and then there is secondary prevention. So this individual has got a stroke and he recovered from it completely, or there is a condition or a event which we call TIA, transient ischemic event. So this is an event which just happens, you get some weakness in your hand or some numbness, and it recovers, immediately recovers. Or sometimes you have this lasting for a day or so and then it recovers. So this is a sign that you have something which is causing this blood supply to that area to reduce, so which could be a narrowing in the artery, which is in the range of around 70 to 90%, or there could be something coming from the heart. So we need to evaluate these patients for all these things and prevent a stroke. So when you have a narrowing in the blood vessel, we do something called as stenting and revascularize this when it is critical and prevent a further stroke, which you can revascularize a vessel in the neck, or also you can revascularize the vessel directly inside the brain. So that is where you do secondary prevention. So primary prevention, again, you have to get down your risk factors like stress levels. Walking is a very good exercise, a 5-kilometer walk, gradually building up to 5 kilometers with the speed ranging from doing 1 kilometer at every 12 minutes, and within an hour, 45 minutes, 50 minutes to 1 hour, you finish the walk. Short step, which is called brisk walking, can actually get down your requirement of your BP medicines, also can keep your cholesterol in check and prevent a stroke, whether it is primary or secondary. So if you already have these risk factors, still you could prevent getting a stroke or even a heart attack, which are almost similar. So any vessels in the body can get blocked, and these risk factors are there playing for it.
So the important aspect of treating an acute stroke is time. So everyone should be aware that time is a factor which decides the treatment. Okay. So a person who suspected to have stroke should come within 4.5 hours. That is the sum and substance of our interview today. Okay.
And when you look at a heart attack, or this we can call it as a brain attack, heart still gives you time. Many times you see a patient undergoing a revascularization procedure on the next day, a day after 2 days. They have given clot bursting agent is given even in heart attacks. So that doesn't happen in brain. Brain has this only narrow window of around 4.5 hours to 6 hours in the front circulation, and in the back circulation may be extended to around 12, and in some selected patients you can extend it to around 24 hours. So unlike an heart attack, you have to be very fast and be fast in stroke.
Thank you
That's
so
what
much.
our effort is, to make sure we bring out, we develop the awareness. Awareness about heart is there. Everyone goes to a doctor if they have some pain anywhere near the chest. But there is lack of awareness about stroke. So we want to develop that awareness so that more patients are treated and they get proper treatment before the disability is setting.
Dr. Charudutt, Dr. Safal, thank you so much for your time. Thank you for enlightening us.
Thank you.
For those of us experiencing any of these symptoms, or anybody around you, if you see them experiencing any of these, you can always rush them to Manipal hospitals at the emergency department, which is open 24/7. Also, if anybody wishes to consult Dr. Safal or Dr. Charudutt, they are available at Manipal hospitals from Monday to Saturday. See you again next week. Until then, eat healthy, drink plenty of water, watch out for any of these signs, and consult a doctor.